Neo-adjuvant therapy options in rectal cancer, and the questions that are commonly encountered in clinical practice. So, unlike cross trial for esophagus and the MRC Grossman trials for muscle invasive bladder cancer, which unequivocally showed an overall survival benefit with the addition of neoadjuvant therapy to upfront surgery, most of the solid organ cancers, neoadjuvant therapy does not provide a survival benefit per se compared to adjuvant therapy. For example, in a locally advanced breast cancer, we give neoadjuvant chemotherapy for converting a mastectomy to a BCS or for axillary preservation or for risk stratified adjuvant therapy approach based on the CREATEX or Catherine models. So, the reason we give neoadjuvant chemotherapy or radiation in rectum can be multifold. Is it for reducing local recurrence rates or distant failure? Does it provide a survival benefit? Is it for sphincter preservation or organ preservation? These questions we'll be discussing in this video. A patient with a locally advanced rectal cancer, even today, will undergo an upfront surgery which will include a bilateral pelvic lymph node dissection in the East, that is, the Japan, China, and Korea. The concept is that the superior rectal artery is a branch of inferior mesenteric artery. The middle and the inferior rectal arteries are branches of internal iliac artery. Similarly, the venous drainage parallels the arterial supply. The middle and the inferior rectal veins drain into the internal iliac veins. So, while by doing a total mesorectal excision and removing all the mesorectal nodes, we may be clearing the nodes that the lymphatics that drain the upper rectum, but the lower rectum and the mid rectum may have additional drainage to the internal iliac lymph nodes. So these are not part of the standard TME surgeries, and these were the reason for the very high local recurrence rates in the pelvis before the routine use of neoadjuvant therapy. So what the West and the Europe and India achieves with neoadjuvant therapy, the East does it in the upfront setting by the use of bilateral pelvic lymph node dissection. So, the treatment landscape of rectal cancers changed when Held introduced the concept of total mesorectal excision, and then three seminal trials established the current standards of care: the Swedish, Dutch, and the German trials. Though TME was introduced in 1986 by Health, it was not globally adopted very quickly. So, in the Swedish trial, many patients underwent non TME surgery, and there was a decreased local recurrence rates and an overall survival benefit with the addition of neoadjuvant radiation. This is one of the two trials that have showed an overall survival benefit with the introduction of neoadjuvant therapy, the other being the PRODIGE 23, which we'll be discussing later. But this has to be taken with a pinch of salt because, as we saw earlier, many patients underwent a non TME surgery. So, in one arm, patients undergo a non TME surgery, and in the other arm, patients undergo neoadjuvant radiation followed by a non TME surgery. So, the radiation provided a survival benefit probably because it compensated for the non TME surgery. Then the Dutch trial, both the arms underwent TME surgeries, good quality surgeries, and despite that, the addition of neoadjuvant radiation in the form of short course RT decreased local recurrence rate at a very long term follow up of 12 years, though there was no survival benefit. Another important conclusion that came out of the Dutch trial was that high rectal tumors and early rectal tumors, T1, T2, and 0, do well with a single modality surgery alone. So now, here we have so before the introduction of TME, the local recurrence rates after rectal cancer surgery were as high as 40 to 50%. With the introduction of TME, the local recurrence rates came down by half, so 20 to 25%. With the addition of neoadjuvant radiation to TME surgery in the Dutch trial and the Swedish trial, the local recurrence rates even came down after the TME surgery also. So it became close to 10%. Now, the addition of radiation has been established very very clearly. The benefit has been established very clearly. So, should this radiation be added before surgery or after surgery? This was addressed in two important trials. The more important one was the German rectal cancer trial, where patients were treated with long course chemoradiation, 5FU based, followed by TME surgery, or upfront TME followed by the same regimen of long course chemo RT. And the neoadjuvant arm experienced a very significant reduction in local recurrence rate without a survival benefit. NSABP R03, again for locally advanced rectal cancer, very similar trial designed to the German cancer trial. Neoadjuvant chemoradiation was better than adjuvant chemoradiation in terms of DFS. So by 2004, it was a global standard of care that locally advanced rectal cancers, that is locally advanced rectal cancers meaning CT3 or T4 or node positive rectal cancers, should be treated with a multimodality approach, and the addition of radiation is best done before surgery. So the standard of care for locally advanced rectal cancer became neoadjuvant chemoradiation followed by surgery. Then came the next few questions. How to choose between a long course or a short course radiation? Because even in the Swedish trial, which showed the survival benefit, short course radiation was used. So this was addressed directly in two trials, the Polish trial and the Australian Tasman trial. The Polish trial evaluated SERT early surgery compared to the conventional long course RT delayed surgery. Pathological complete response rates were higher in the conventional arm, but there was no difference in the local regional recurrence rates or disease free survival. The Australian trial, also the TROG trial or the Trans Tasman trial, also both SERT and long course radiation had very similar local regional recurrence and overall survival. But both the Polish trial and the TROG trial were not powered to show equivalence of short course and long course, and both had a very short follow up duration. And most importantly, both were pre MRI trials. The inclusion criteria was just mobile tumors on digital rectal examination. That is all. So fixed tumors were excluded. So these cannot be the interpretation of these two trials that short course RT and long course RT provide equivalent local regional recurrence rates and DFS cannot be generalized to clinical stage T4 tumors, bulky tumors, or significant lymphadenopathy CN2, or when the mesorectal fascia is involved or threatened. This should be remembered that SCRT should be used with caution in such tumors. Of course, SCRT is resource sparing because the entire treatment duration gets done in 5 days, but it has been proved that SCRT leads to effacement of the plane between the rectum and the levators, making sphincter sparing surgeries quite difficult, technically difficult. Now, we have established that we are going to give neoadjuvant therapy in the form of chemoradiation for locally advanced rectal cancers. So, when should we operate after this neoadjuvant therapy? Two trials widely quoted are the Stockholm 3 and the Greca 6. The Stockholm 3 had three arms: SCRT followed by a surgery within 1 week, SCRT followed by delayed surgery, and long course conventional chemoradiation arms. The trial started in 1998 and it took 15 years to accrue, and it was amended after just 1 year of commencement to allow to accrue only the two arms with short course radiation. Most importantly, there was no chemotherapy in any of the three arms, making the interpretation of these results very difficult. And we cannot generalize these results to our clinical practice. But both long course conventional chemoradiation and short course radiation followed by a delayed surgery appear to be reasonable options. In Greca 6, the convention after a long course chemoradiation, patients were operated after a waiting period of 7 weeks versus 11 weeks. And it was noted the conversion rates from MIS to open was significantly worse in the longer waiting period arm, and the quality of mesorectal dissection with higher numbers of mesorectal breach and positive margins were significantly worse in the patients who were waited for a long time. So, guidelines generally recommend a waiting period of 6 to 8 weeks after chemoradiation for surgery. But now, with the advent of TNT, whether we use long course or short course, irrespective of that, between chemo radiation and surgery, there is a 22 to 24 weeks gap in which patients receive systemic therapy. So, what happens to the quality of mesorectal dissections when patients are waited for 22 to 24 weeks when is being implemented? Is a question to answer. We'll be discussing this in a few slides. So now we already established since 2004 that neoadjuvant chemoradiation followed by TME followed by adjuvant chemo is the standard of care for locally advanced rectal cancers. So what is total neoadjuvant? It does not necessarily mean giving the entire thing, all the treatment before surgery. It can be some chemo or all chemo before surgery, and that can be used along with either long course radiation or short course radiation. And again, it can be used before the radiation or after the radiation. So in the trials which evaluated TNT, there's so much heterogeneity in the trials in terms of all these components. All these would constitute TNT. TNT basically means shifting some or all chemo before TME. That can be before the chemoradiation or after the chemoradiation, and it can be either long course or short course. So, when we are implementing some TNT trial protocols to our clinical practice, we should know the inclusion criteria of these trials and whether our particular patient fits into this similar inclusion criteria. The whole concept was behind the whole Achilles heel behind TME was that with all this, with TME, with the addition of radiation, with the addition of neoadjuvant radiation, we have significantly reduced the local recurrence rates from 40 to 50% to less than 10% now. So now we are successful in terms of local control, but patients are failing in distant sites. So, to reduce distant metastasis, we need systemic therapy. Quite logical. But post operatively, many patients may not be fit enough to complete the adjuvant systemic therapy. The tolerability may not be that good. They will be having a stoma, complaints may not be that good. So, that is why the concept of TNT with the addition of systemic therapy before TME surgery came into the picture. The main proposed advantages are decreased distant metastasis, improved tolerability of systemic chemo, and improved compliance so that the entire treatment can be completed. Another new concept of the reason for increased use of TNT is the ability to preserve organs without a TME surgery. We'll be discussing these now. So, as we see that the NCCN guidelines for the same group of locally advanced rectal cancer, that is T3 or T4 or node positive disease, has been evolving as and when evidence accumulates. So, in 2015, the recommendations were mainly for long course radiation, and in 2017, short course radiation came into the picture, but it was again not recommended for T4 tumors, and chemotherapy followed by long course radiation was again introduced in 2017 based on a phase 2 trial. In 2018, this group was divided into two, those with negative CRM and those with involved CRM. And again, main options were long course or short course chemo radiation or chemo 2 cycles followed by long course radiation. Now, interestingly, 2024 NCCN guidelines for the same population of T3 or T4 or node positive, that is locally advanced rectal cancer, just gives a blanket statement of total neoadjuvant therapy. It gives us three options, that is a long course chemo radiation or a short course radiation followed by chemo. So this is a TNT in which chemo is used after chemo radiation, that is consolidation chemotherapy of TNT. Here, an induction chemotherapy is used, followed by either a long course or short course radiation. So, this is also TNT. The third option is giving only chemotherapy, reassessing with a MRI and sigmoidoscopy, and based on the level of response, selective use of radiation if the tumor seems to be responding well with more than 20% regression to chemotherapy. So continuing chemotherapy only and avoiding radiation and going ahead with the TME. Whereas in poor responders, so chemo does not seem to be working well, so the introduction of radiation. So this was mainly aimed at avoiding radiation. So we'll be discussing each of these three available protocols in detail now. The problems with this guideline: T3, T4, or N plus. So all these things are put in a single box, a single basket. So a T3N1 cancer of upper rectum is put in the same box as a T4N2 cancer of lower rectum with extramural vascular invasion. It is put in the same box as a CT3D N1 mid rectum. The principles of treatment of these three would be extremely difficult, and also factoring in other factors like the goal of the neoadjuvant therapy in that particular patient factors like age, comorbidity, fertility concerns, or motivation for organ preservation, compliance for surveillance protocols for organ preservation. There are so many factors that need to be factored in while taking decisions making. We cannot put all these patients into a single box and say there is a single treatment that is total neoadjuvant therapy and we'll follow this for everyone. So it is like putting these two patients of breast cancer LABC in the same box: a 40-year-old premenopausal woman with TNBC and a 55-year-old postmenopausal woman with a hormone receptor positive HER2 negative LABC. After 4 cycles of EC, the neoadjuvant chemotherapy that was given for in an attempt for breast conservation, the responses are different. And now at this point, we cannot place these two patients in the same box and say we would treat these two patients in a similar way. So, very similarly, while choosing a treatment protocol for a particular patient, we need to factor in patient factors, the goal of neoadjuvant therapy in that particular patient, and we should periodically monitor the response of the initial therapy that we are giving and tailor further therapy based on that. So the three main trials that are widely quoted while discussing TNT are the Rapido, PRODIGE 23, and the OPERA trials. So while analyzing these in detail, Rapido included high risk rectal cancers which needed to have at least one of the following factors, that is a CT4 or N2, or extramural vascular invasion or lateral lymph node positivity or involved or threatened mesorectal fascia. But interestingly, only 22% in the TNT arm and 26% in the conventional arm had a low rectal cancer. So, predominantly, more than 75% of the study population were mid rectal and upper rectal cancers. It is very, very important to remember this. So, while implementing Rapido trials interpretation in our clinical practice, we need to know that the majority of the trial population were mid and upper rectal cancers. About 20% in each arm were low rectal cancers. So the experimental arm was short course radiation followed by chemo and TME, and the conventional arm was conventional long course chemo radiation followed by surgery, and the adjuvant chemotherapy was optional. Again, a very important point to remember: 58%, almost 60% in the conventional arm, in the control arm, did not receive systemic therapy. So, as we saw earlier, the main aim of TNT, one of the main aims was of TNT was to reduce distal metastasis. Rapido was successful that way. It was a positive trial in achieving a lower 3-year distal metastasis, a 7% difference in the 3-year distal metastasis between the TNT arm and the control arm, and a PCR rate that is double that of the control arm. But it is important to note that 60% of the control arm did not receive systemic therapy. So this arm, the TNT arm, had a significant advantage in terms of 6 months of systemic therapy over the control arm. So that might have been the reason for the decreased 3-year distant metastasis. And so many patients had the in breached mesorectum in the experimental arm. 21% had breached mesorectum with a higher loco-regional recurrence rates. So we saw this when we were discussing here that with the introduction of TNT, the time interval between chemo, radiation, and surgery has been prolonged significantly, as opposed to what was seen in the Grecar 6 trial. So this might be one reason, and adding to that, we know that short course radiation causes effacement of the planes between the levators and the rectum, causing poor mesorectal dissection. So all these factors might be the reasons of increased mesorectal breach and increased local recurrence rates seen in the experimental arm of Rapido trial. The reasons that are also cited and reported are the use of 3D conformal radiation rather than IMRT, which is the current standard of care. The 3D CRT might have caused some marginal misses in the radiation fields, and the use of minimally invasive surgery for locally advanced rectal cancers by surgeons of varying experience, because there is a general learning curve, and during the earlier part of the learning curve, it is a well known fact that the local recurrence rates are going to be higher. The next most important trial is the PRODIGE 23, where again high risk locally advanced rectal cancers, so T3 T4 are node positive, but only 21% had involved with threatened mesorectal fascia. Only 16% of the trial population were T4, and there was absolutely no mention about extramural vascular invasion or lateral node positivity in this trial population. So the control arm was a standard conventional long course chemoradiation followed by surgery. But the advantage was that adjuvant chemotherapy was mandated in PRODIGE 23, where it was just optional in Rapido trial. The experimental arm was a very intensive arm, 6 cycles of triplet chemotherapy, not just Folfox, not just 5-fluorouracil. It is 5-fluorouracil plus irinotecan plus oxaliplatin, followed by long course chemoradiation. So both the arms had long course chemoradiation followed by surgery. Again, adjuvant 6 cycles of Folfox or CAPE. So the main one of the main aims of TNT being reduced distant metastasis, very similar to the Rapido trial. PRODIGE also achieved a lower distant metastasis by around 7 to 8% in the experimental arm, that is the TNT arm. Very similar to the Rapido trial, again, the pathological complete response rates were higher, almost double in the experimental arm. Local regional recurrence rates, which were higher in the Rapido trial, were not seen in the PRODIGE 23. Most importantly, this is the second trial after the Swedish trial of 1990s that has shown an overall survival benefit at a long follow-up. Though Stellar did show an overall survival benefit, we will not be discussing Stellar in detail because Stellar needs a longer follow-up, and Stellar showed an overall survival benefit without showing a DFS benefit or decreased local recurrence. That needs a lot of statistical discussion. So at present, PRODIGE 23 has shown a 7% overall survival benefit with the use of TNT. So because of this, probably the NCCN guidelines has include TNT as category 1 recommendation for locally advanced rectal cancers. But that does not mean we should be giving this protocol to all the patients with locally advanced rectal cancer. This improvement in overall survival, we are not very sure if it is just because of the addition of the third chemotherapeutic agent of irinotecan. It may well be possible. The third important TNT bar organ preservation trial that's talked is the OPRA trial, where both arms received long course chemoradiation, but in one arm, chemo was given before the chemoradiation, so induction chemoradiation, and the other arm was chemoradiation consolidation chemo followed by TME. The important conclusion of this trial was the organ preservation rates were significantly higher in the consolidation arm. That is, when chemoradiation was given first, followed by chemotherapy, 54% patients could preserve their rectum, were able to conserve their rectum. So this also proved that TNT is a very safe method of treating locally advanced rectal cancers. Now, we have talked about TNT so much. Now, is TNT, there is a very common misconception that the bulkier the tumor, uh, the higher the stage, the more chemo the patient requires and would obviously require TNT. And the smaller the tumor, early rectal cancers should not be given TNT. This is a very, very common misconception, a very important point to remember. TNT can be considered even for early rectal cancers when organ preservation is the goal for the patient. For example, a typical patient would be a low rectal cancer with involvement of internal sphincter. Internal sphincter is basically continuation of the muscularis propria of the rectum, which would make it CT2. So the intersphincteric space would be free, might be free. So an upfront intersphincteric resection can be attempted, but it is known to cause a lot of quality of life issues and a lot of incontinence. In such patients, use of a TNT can achieve a clinical complete response and subsequently an organ preservation in up to 40 to 60% of patients. And even otherwise, even if the other 40 to 60 who do not achieve a clinical complete response, they can be subjected to a safe local excision, which might not have been possible prior to the use of TNT. This was proved in the ACASOX 6041 trial that local excision is safe for low rectal cancers, that is T1 or T2, after neoadjuvant chemoradiation. The worst case scenario might be a salvage TME in case of poor responders after TNT. Now, the last aspect of these guidelines that we saw as a part of the NCCN guidelines is, so we have discussed TNT in detail. Now, selective use of radiation: give chemo, assess response, and use radiation selectively. So this is based on two trials: the FOWAC trial, which basically tried to prove the superiority of Folfox radiation over 5FU radiation. It had three arms: 5FU radiation, Folfox radiation, and Folfox alone, but accidentally ended up proving that Folfox alone is equivalent to or non-inferior to Folfox radiation and 5FU radiation, because all the three arms had very similar locoregional recurrence rates, DFS and OS. So this led to the thought that we might as well avoid radiation or use radiation selectively. So this was prospectively studied in the Prospect trial. So, very important to remember again, inclusion criteria of this patient, exclusion criteria of this trial was T4 or N2 or close margins or low lying tumors. The median distance of the tumor from anal verge in this trial population was 8 centimeters. Most of them were upper rectal tumors. So basically, many of these patients did not even need a neoadjuvant therapy in the first place, but still they received neoadjuvant chemo, and then they were assessed for response. And patients who had a good response, that is more than a 20% regression, then were subjected to TME followed by adjuvant alone. So these patients could avoid radiation. And when patients had a suboptimal response, that is less than 20% regression, chemoradiation, that is the conventional standard of care, was introduced into the treatment, followed by TME and adjuvant. So it showed that selective use of radiation is feasible and safe, but it is to be taken again with a pinch of salt, because this trial did not evaluate low rectal cancers or bulky T4 tumors or with